Morning, everybody. It's a 5-minute warning, no panic. Just checking that you're all got the Wi-Fi code, which is new green with a capital N and a capital G and no space. Is that right, Tom? Yeah. Okay. 5 minutes, coffee at the back, and we'll be going hopefully on time. Thanks, everybody. Everybody's very quiet this morning, prepared. A 1-minute warning, I think. Are we ready when you guys at the back, when I give you the thumbs up? Yeah, okay. 1 minute, everybody. Okay, so 9 o'clock. Everybody ready? Shall we go? Are we streaming? We are. Right. Good morning, everybody, and welcome to the Suffolk and North East Essex Integrated Care Board meeting for March. So if I could give everybody a reminder that we are live streaming, and then a little bit of an intro from me, and we'll hit the agenda in the normal way. I think it's probably fair to say that everybody will recognise that we're in a fast-moving world at the moment with a lot of change happening, not all of which is clear to us in terms of where it will end up. So I know that we'll all extend our sympathies and empathy indeed to the workforce, the workforces that we have in total in the system, with the degree of uncertainty that is before them. So our thoughts are with everybody out there, and I think all we can say at the moment is actually it's so fast moving that what we thought was going to happen on Monday, we then hear on Tuesday either isn't going to happen, or is going to happen even faster, or is going to happen differently. So there's a lot going on at the moment, but certainly a lot of uncertainty. The most important thing is that we continue to work together and explore all the viable options that there are before us. So I think we can give that assurance, although not necessarily the assurance that particularly our workforce would actually deserve and need at the moment in terms of where we're going. So with that in mind, I'll then move us on to a little bit of agenda management. As you may know, item 7, the 25-26 priorities and operational planning submission, we're not going to deal with today. Although, Richard, I may ask you just to say a few words, but I do mean a few words by way of pitching the position on that. But we have a special board meeting tomorrow at 6 p.m. virtual, at which that item will be considered. So with that change to the agenda, the public meeting today, we're going to target finishing at 11 o'clock because we've taken a considerable amount out of the agenda, obviously, with that item moving to tomorrow. So if we can finish the public at 11, we'll then have a coffee break and go into private session at, say, 11:10, 11:15. If we can finish the private meeting by 12:15, we'll then effectively have a development session, an informal meeting of the board with colleagues around the sustainability review in terms of a development meeting for those who can make it. If we can, we'll be finishing then at about 1:15, thereabouts. And with that in mind, Tom has cancelled lunch to make sure that we actually don't waste the money on lunch, because we're all disappearing to go to those urgent things that we've got before us. So that's the plan for today. The introductions, I think, Melissa, if we could welcome you to the meeting. You're shadowing Lisa today, so I don't think we've got anybody else new around the table to welcome. Apologies, I think all I've got, Tom, is Caroline Donovan, and Kath, you're here for Caroline, and then Maddie Baker-Wood and Edward Creasy. Are there any more, Tom? Oh, yes, thank you very much for that. Noted. Lovely. So, questions, item 2, questions from members of the public. We've actually got 9 again, and if I could remind people that questions should be targeted at agenda items on the agenda for the day. And we are going to have to be more strict about this going forward. I think I did indicate at the last meeting that we held at Ipswich Town Football Club that would be the case. But we'll take all our questions given that we have 9, we'll take them at the end of the meeting. Declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we are aware? None raised, in which case minutes of the last meeting, the 28th of January, the one at Ipswich Town Football Club. For truth and accuracy first, please, let's take them en bloc. Are there any points of accuracy in the draft which has been circulated? Yeah, Kath?
There's just a few factual bits like job titles, etc. So shall I pick that up offline?
Yes.
No material change to the
No
minutes.
material change,
No.
but some typos effectively in job titles. Okay, so subject to correction of those, which you'll pick up with Tom for the file copy. Is everybody content that the draft as circulated is a true and accurate record? Agreed. Thank you very much. In which case then, let's move on to item 5, which are the matters arising. Now, subject to 2 updates, which I'm going to ask colleagues to give, as far as I could tell, all the matters arising were either complete or are on the agenda today specifically, or are work in progress, ongoing and not yet due. But 2 updates, if we can, please. First of all, Andrew, could I ask you to give an update on Res and Des, please?
Yeah, thank you. So formal paper will come back to the board in May on the Res and Des results from the staff survey in 2024. But I wanted to give you a verbal update now about work in progress, given that it's been some time since we presented that paper here at the board. We took a decision in our executive team to really take the learning from Res and Des down through the organisation, and we presented the findings several times with our directors and deputies within the organisation, and they have been tasked with coming back with internal directorate plans for how they're going to deliver on the Res and Des and other aspects of the staff survey relating to equality, diversity and inclusion. We are collecting that at the moment. We have agreed that we're going to deliver cultural safety training to every member of staff within the Integrated Care Board, and that is starting in the late spring. We have agreed that we're going to start a 3-monthly pulse check within the ICB to check on several criteria within the staff survey, but also including questions from the Res and Des criteria to make sure that we monitor that in real time. We have become more involved and more strategically involved in the system EDI group, and I'll be looking for board level sponsorship of that in due course as well from our partner members, because that's not immediately clear from the group as it currently stands. And we are planning to continue to publish any results that we get from the work that we're doing to make sure that it is obvious to our partners and also to our public of where we are. So you should receive an update, particularly on the directorate plans for delivering equality, diversity and inclusion improvements at the board in May. But I hope that verbal update is helpful.
Thank you, Andrew. Any questions on that? Noted. And then Lisa, could I ask you to give an update, please, on the Certif outreach, which was originally scheduled for today, but I know you've got an update on that.
Thank you. Yes, we were due to bring an update report today. However, we're waiting for the national framework from NHS England. So we thought it would be more meaningful to bring an update in May once we've got the national framework and the national timetable for submission of action plans from the trusts is the end of March. So we'll bring both those items forward in May.
Okay, thank you. Any questions on that? So in taking the matters arising now as a whole, is everybody content with the actions taken? So endorsed, and then is everybody content that the matters arising record itself is complete, or are there any other matters arising you think should have been in that list from particularly from January? Agreed as complete. Oh, and yeah, Mr. Dooley. Yeah, come on, Mr. Dooley.
At the last meeting, I asked whether the NSFT would apologise for the consequences.
You've got a microphone coming, Mr. Dooley. Yeah.
At the last meeting, I invited the NSFT to apologise for the fact that under its radical redesign, it abolished the assertive outreach teams, and I made reference to the Suffolk team in particular that I was aware of, which were doing superb work. Is that apology available?
Kath, I think I'll have to come to you for that one, if I may, please. And then I'll come to Lisa. Do you want to go first, Lisa? Or, yeah, sorry.
Thank you, Anthony. So obviously, as we discussed last time, the ring-fenced funding for assertive outreach teams was removed a number of years ago. However, we do recognise it's a really important function. NSFT and EPUT have now gone through all their cases that the community mental health teams hold. They know exactly which people should be seen under an assertive outreach team. Once the new framework is released by the national team, we'll be able to move forward with that, Anthony. But it was a national issue around assertive outreach team funding.
Okay, thank you, Lisa. Do you want to add anything to that, Kath?
No, I think just to add, thank you, Lisa, for that. I think locally and nationally, the lack of the assertive outreach has had impact across the country. And we know the CQC are undertaking a national review currently and inspected NSFT last week. We're obviously awaiting the outcome of that, and that's linked very much to the lack of assertive outreach services across the country. So every provider is being inspected on that. So we will await. But as Lisa has said, there has been an enormous amount of work in dealing with it from a perspective of how do we ensure that our service users are safe and cared for appropriately now in the absence of that formal service. Thank you.
Okay, thank you both. Is everybody now content that the matters arising record is correct from the 28th of January? Yes, 28th of January meeting. Correct and complete. Done. Okay, thank you very much. In which case, item 6, the CEO's update. Over to you, Ed.
Thanks, Chair. I echo your points around empathy and kindness towards our staff at the moment. So there's significant changes in the leadership of the health service up and down the country. So NHS England is due to be abolished and will be brought together with the Department of Health and Social Care. That will reduce duplication and free up resources for frontline investment. In a similar fashion, slightly different, but ICB's running costs will be reduced by 50%. We don't have all the detail on what that means in practice, but we will be reviewing kind of viability of ICBs and working out whether we need to come together with neighbouring ICBs in the future to be sustainable. So there's a significant amount of work to do. But in the meantime, doing a lot to support our staff and to communicate regularly and to keep people focused. In a similar fashion, there is, I think, direction coming down around provider corporate costs and getting back to 2018-19 levels as well. So reductions in the providers too. And then outside of the health service, there's obviously local government reform and significant conversations going around potential unitary councils, mayoral authorities and so on. So a significant period of change at a time when we have a significant task to do around delivery. On delivery, thank you to all colleagues involved with planning. So in our footprint, we've got the ICB, West Suffolk Foundation Trust, the Ambulance Trust and ESNEFT. We will be submitting our plan this week, the 27th of March, and I think we'll have a largely compliant plan, which is excellent. So thank you to everyone for their efforts. We've also been running our work on sustainability, which we'll hear more about later. So a significant amount of work on planning at the moment. We received and hosted the Duke of Gloucester, who officially opened the dental centre at the University of Suffolk earlier this month. It was a very special occasion. Over 4,000 patients have already benefited from dental care at the university site and excellent patient feedback. So we're really excited about how that's progressing. Congratulations to Lisa and team. So the SNE LMNS local midwifery neonatal system have won a national award for reducing smoking in pregnancy by over 50%. So fantastic achievement for all of the trust-based teams and the ICB colleagues as well. So thank you very much for that achievement. The Haverhill Hub has been opened by Unity Healthcare, which has been a brilliant example of collaboration, actually, Chair. So the West Suffolk Council, I think, have invested a couple of £1 million to create the hub. It's being used for admin and kind of e-consultation purposes and freeing up capacity for frontline care. So really, really great to see that in Haverhill. All our GP practices now in SNE are veteran friendly. I think we're the first ICB in the east of England to have that status, and only the third nationally. So we're really pleased that we're supporting our 8,000 veterans more effectively now. I wanted to recognise the Super Saturday initiative at West Suffolk Foundation Trust, where they're doing particular work on ophthalmology, orthopaedics, plastics and general surgery, around 47 procedures a day. So I think that's really helping tackle the waiting list there. And on urgent emergency care delivery, last year we're very close to our 78% mark, which is we're required to deliver in March, by the end of March. And there's been a significant improvement in C2 performance in the ambulance trust and in ambulance handovers. So some very effective work across the system and urgent and emergency care. Final two things is very well done to Amanda and all the colleagues. So we've had the staff survey through for the ICB. We've got the top results in the country for ICBs, and particularly have done well on compassionate care and staff engagement. So it's a really, really big achievement, and to have improved it from last year at a time when we were taking 30% out of our running costs is excellent. Finally, we are organising an expo for our system, as we do annually, for the 4th of July. Susanna will brief us more on that, but I'm sure it'll be an excellent event as usual. Thank you, Chair.
Ed, thank you very much. Some great news there. Any questions for Ed? Elaine?
Yeah, thank you. I wanted to just come in a little bit on the organisational changes, if I may. So I appreciate that is probably quite unsettling for many people to work through, including yourself. It would just be helpful to understand a little bit more about the expected impact, if any, on the health services for the population, as that's worked through, and also how the staff are being supported as well. That'd be helpful. Thank you.
Thank you. I mean, it's very early days, so it's difficult to answer that precisely. And maybe, Amanda, if you wanted to come in about supporting staff in terms of impact on health services, I don't think we could call that now. It's worth saying that there is a kind of a provider element to the ICB in terms of continuing healthcare, which is crucial for the population. And if we're reducing down to 50%, we need to make sure that we've got a viable team to continue that service. Same with GP prescribing. So I think these are all issues we're working through once we've got more detail, and I think it's probably something for the action plan, if that's okay, to come back to give you a full answer. But yeah, we've had the headline, but we haven't yet had the detail, Elaine, so it's difficult to answer.
Yeah. Did you want to comment, Amanda?
Indeed, I will. Thank you very much, Chair. Thank you, Ed. So, as we know, Elaine, we don't have a plan yet, but what we have got is a good emerging plan. And on the back of last week's announcement, we've already started working through with our staff the level of support required, and some of that has already started. So to give you an example, mental health first aiders, we have a good cohort of those that are up to date with their training. We're offering that support. We're offering coaching, mentoring, counselling, occupational health. So we have a really good, robust package of support that we have started to roll out, and that will continue as we know more in the coming weeks and months ahead.
Thanks, Amanda. And just before I come to Nick, one of the things you might care to raise, Elaine, under the BAF item is risk and risk management around, which I know Amanda will comment on as well. But okay, thank you. Nick.
Thank you, Chair. So I think this is an opportunity for us as a system to come together to support colleagues. I think it is disappointing to see the approach that's been taken, a broad brush approach to all ICBs across the country, not recognising that some ICBs for the same size population have half the running costs of others. And I think it's important to put that on record. Well, my disappointment that that approach is being taken without recognising the success or the relative success of some ICBs. So really wanted to offer my and ESNEF's support to colleagues going through this. It's incredibly difficult because whilst facing anxiety about one's personal future and the team that you've worked with and developed over several years, we're also required to keep doing the day job. So I just wanted to recognise how difficult that is. And if there's any support from ESNEF or the organisation or that we can offer through our wellbeing service or anything else, I'd just like to make that offer. But I think it is a time, there will be, there's perhaps a little bit of, I don't quite know what the word is, but a kind of thank God it's not us from the provider sector. But given the challenges of the NHS, what's happening within the ICBs and wider today will be something that we'll have to address going forward. We know that the NHS is not fit for purpose for the next generation. So those challenges which we all face as an ICB board will be faced more widely. So I think it's recognising the difficult time that colleagues are going through, offering the support, but also wanted to put on record my disappointment about the approach that's been taken. And frankly, the way that staff found out on the BBC website, I think, isn't the way to support staff at a difficult time. Thank you, Chair.
Thank you, Nick. Thank you. Any other questions for Ed on the CEO's update? So received and noted. Thank you very much. In which case, let's move on to item 7, which is the largely deferred item. But Richard, you're going to say a few words by way of explanation and the plan.
Thanks, Chair. So Ed's already alluded to the fact that we are due to submit our annual plan for 25-26 to NHS England by the deadline of Thursday. As Ed's alluded to, we're pretty much there, about 90% of the way there now, and we are broadly going to be putting in a compliant plan. We just needed some bit more time to work through particularly the financial side and also make sure it all triangulates, which is why we've now created with the Chair's agreement, the extraordinary board meeting tomorrow night. So I will save the detail for them rather than starting to go through it now. But yeah, Wednesday evening is when we'll go through it.
Wednesday, 6 o'clock.
Yeah.
Yeah. Okay. Any questions on that and the plan for the plan, as it were? Noted. Thank you very much, Richard. In which case, I'm going to stick with you, Richard, if I may, for item 8, the JFP update, please.
Thanks, Chair. So hopefully it's a fairly straightforward item that you'll see in the pack. So our joint forward plan is effectively our operating plan for the organisation over a 5-year period, rolling period. We are expected to update that every year. This year, we've been asked to do a very light touch review by NHS England, given the national 10-year plan is due to come out in spring or early summer. So therefore, it didn't make sense to ask ICBs to do a huge kind of change when we don't know entirely what's going to come out through the 10-year plan. So you'll see in the pack, effectively, therefore, we've done a light touch review. We've updated where things are now slightly out of date. We have done a review of the key performance indicators, and we did recommend as an executive that we didn't do a huge substantive change to those. So what you'll see is an update where we need to be aligned with some of the national changes in the planning guidance. But other than that, we've still stuck with the commitments that we made. Obviously, in the context of what Ed's updated on about ICBs and some of the wider changes and the 10-year plan coming up, I expect there's going to be a bigger redrafting of the plan for 26-27. It's gone through exec approved and recommended here for publication by the end of March with the national deadline.
Thank you, Richard. So, Richard, I know you'll take any questions if there are any, but is it your and the exec team's recommendation that we approve the plan today effectively as a in a way, as a working draft, if you like, a current update, noting that we'll have to revisit this again, probably in the summer, but that would be the theory. But as soon as possible after the 10-year plan has been released. So on the future board meeting yet again.
Yeah, I would say that. So we'll need to start work again anyway towards late summer, early autumn anyway for the following year, particularly if we need to do a significant rewrite of it. So that would make sense.
So with that caveat, are there any questions as presented? Elaine?
So recognising that it is going to be refreshed, it's really more just a couple of points to consider as part of that refresh. So first of all, it's really good to see the indicators, the 22, that give that line of sight to whether or not success is being made against the aspirations. One thing would be, I did notice that for both the A&E targets to be less than 4 hours, so 95% of people seen within 4 hours of going to A&E, that there is no kind of target date for that. So it would be really good to see, even if it's not in a year, that there is a direction of travel to get back to that place. And also the other area I noticed around the elective waits, to bring that back down to within 18 weeks, because obviously we're seeing a lot of people waiting very long times for operations. So I think it's just having a line of sight to over those periods would be good, over the period that those things can be addressed. And then the second thing is just really looking at some of the metrics. Another one I saw was around dental activity. And whilst there's a target to improve dental activity, the thing that really matters to people is that they can see a dentist when they need one. So just an ask to look at making sure that the measures are the ones that matter the most to people. Because whilst we can see an increase in activity, that doesn't necessarily mean people can still see a dentist. So just really a couple of things to consider in the refresh.
Okay, so, and again, I'll generically, your request as well, Elaine, sounds like it's a request for continuous improvement and reflecting the need for that. But Richard, would you like to comment on that?
Yeah, no, just briefly. So for the A&E target, we've aligned the 25-26 target with a national expectation, which you'll see come through tomorrow night in the planning guidance. There is no national yet set timeline to go back to 95%. What we've said on the KPIs and to return towards the national 95% standard. But I was keen not to be too ambitious, and effectively, let's see what comes out of the national plan in summer. And then there's a conversation, I guess, collectively, whether we want to go ahead of the national ambition against 95, which is where I would look to you and Nick and clinical colleagues for a view around that. On the RTT, the referral to treatment, there is an expectation the government has set by 2029, so this parliamentary term, that we will collectively get back to 95%. So again, I think we should align ourselves with that timeline, again, unless the trusts feel that we should go ahead of that. But I just want to kind of not be too ambitious, but at the same time, be realistic around what we're doing. I don't know if Peter wants to come in on dental.
Yeah, so it's, so the targets reflect what we're required to report on nationally. There's a change this year nationally in that we're asked also to record the amount of people accessing urgent dental care and to increase the number of people accessing urgent dental care. And so the units of dental activity that's in there includes that. But you're right to point out that that's a very imperfect measure of us offering a successful oral health service to our patients. So I think the urgent care is a key development this year. With other indicators we're looking at as a dental team, but in terms of what we are required to report nationally, total UDAs and urgent care access are the two key points. Thanks.
Okay, so noting the points raised by Elaine, and that we'll be revisiting all this again in the not too distant future, is everybody content to approve the JFP for today as presented with those comments noted? Agreed? Lovely, thanks very much everybody. Item 9, the implementation of the recommendations following the death of Jack Last. This is a 6-month update as requested by the board from Andrew. Over to you, Andrew.
Thank you. I will take the paper as read. There's quite a lot of detail in the paper of what's happened since we heard about the investigation into the death of Jack Last. It was important to me to follow up on that because, well, for two reasons. First of all, although the recommendations are made towards other organisations and not towards this ICB, I thought there were things that we could and should be doing internally to make ourselves safer. And the second reason I really wanted to follow up on it was because there was some deeper thinking and reflection for us all to do on Jack's death and how we respond to that internally. So with those two purposes in mind, I convened a task and finish group comprising people from across the system who are involved and interested in the learning from that incident. And we have put a number of actions into place already, and we'll continue to work on the rest of them. But in brief, we have made some, I think, significant changes in the way that we use shared data to improve the safety of the use of shared data. We have adopted the data provision notice, which addresses how practices manage data when patients die in over 70% of our practices, and we're continuing to work with the remainder of GP practices to ensure that they have safe and compassionate processes in place that process patients' information after death in a responsible way. And we've escalated to the NHS England National Quality Board on the recommendations that were made, and we'll continue to work with them to support them in assessing and reacting in the way that they think is suitable. So I would propose that, unless requested, we don't bring any further updates on this investigation back to this board unless there's a substantive change from elsewhere. But obviously, if I become aware of any changes that are relevant to this, I will bring them back here for information. Happy to take any questions.
Okay, thank you. Any questions on this item? Otherwise, we are receiving and noting. Agreed? Lovely. Thank you very much. Thank you, Andrew. Item 10, the progress on the leader work. Lisa, over to you.
Thank you, thank you. And the board will remember we brought the 7 priorities at the last year that the board approved, and in the paper you will see an update as to where we are against each priority. So we are on track to meet most of the priorities. We are certainly on track to improve the quality and uptake of annual health checks, health action plans, and the uptake and accuracy of the GP learning disability registers. That's an incredibly important part of people with learning disabilities and autism's lives, and it really helps to keep them healthy and to prevent early death. We've been doing some significant work on priority 2, which is to improve the awareness of the Respect tool. We're tackling this in 2 ways, really. The first is to make sure that all practitioners are trained in how to work with people with learning disabilities and autism towards their end of life, and to make reasonable adjustments when using the Respect tool. But secondly, also empowering people and their families to understand what the Respect tool is and to understand what reasonable adjustments should be made for them. Number 3, there's a lot of activity happening around the uptake of age-related screening and immunisations. The board will remember I brought 2 case studies where screening and immunisations had not happened for those 2 people, and again is a really important element of keeping our people healthy. The priority 4 is the training. So the Health and Social Care Act requires all providers to ensure that their workforce are trained in learning disability and autism appropriate to their work. And we've been really punishing with our target for this, but we have met the target of 30% of the NHS workforce attending Oliver McGowan training, which is really, it sounds very low, but nationally we are leading with that. So that's really incredible. We do now have all organisations as part of our collaborative receiving Oliver McGowan training. West Suffolk and the East were a little later joining the collaborative, but they are now sending people on the training, so that's great. And we're looking at what next year looks like with developing and continuing to provide Oliver McGowan training. Reasonable adjustments in providers. So that's a key area that comes out of nearly all our leader reviews, that reasonable adjustments were not made for people with a learning disability or autism. And making sure that people receive reasonable adjustments is a key priority for us. So we are really encouraging providers to record reasonable adjustments. There is the digital reasonable adjustment flag, which means that wherever, if reasonable adjustments are recorded, wherever that person presents in health, it will be flagged to them. So a reception staff member in the emergency department, where if somebody doesn't normally present to that emergency department, they will be able to see what reasonable adjustments should be made for that person. So it's really important to make sure that we are clear around our use of reasonable adjustments, and we would encourage providers to make sure that they are auditing compliance. One of the other priorities that came out was around a continuity of care model in our specialist learning disability services within Suffolk. So we are aiming for one workforce that moves across our community and our inpatient services. And there's been a lot of work you'll see in the action plan done to progress that, but we haven't yet achieved a one-team approach, and I don't think we will achieve that this year, but we will be putting forward that as a priority to roll over for next year. And lastly, prevention of respiratory illness. So there's a lot of work happening in providers around respiratory illness and primary care that we are making sure that we are linking into, but again, empowering and supporting our communities and our care providers to understand how to prevent aspiration pneumonia is an approach that we're using. So we had a Better Care Together learning event, which had 160 people in our communities that came, and there was specialist teaching sessions by physiotherapists and multi-agency workers, educating families on on positioning and feeding and lots of areas to prevent aspiration pneumonia. And we have a second event planned on epilepsy and preventing, supporting people with epilepsy, which Andrew is going to do a star presentation on. So we are making progress. The governance is much better. There's still a lot of work that we need to do to improve the governance for LEADER. It was previously reporting into the System Oversight and Assurance Committee, but will now be reporting into our Quality Committee, where we'll be able to escalate any barriers or concerns that we have to achieving. Thank you.
Thank you, Lisa. And noting the Quality Committee's future engagement on this and the work on governance, etc., still need to be done. Your next update, would I be right in thinking that would be the annual?
Yes.
In the autumn?
Yeah, it will be the, obviously, achievement of this year's priorities and setting priorities for next year following this year's learning from the deaths of people with learning disability and autism.
Okay, so, and Tom, you will have got that on the forward planner for receipt by the board in the autumn. Yep, noted. Good, thank you. Fanuel.
Thank you, Chair, and thank you, Lisa, for that. So I just wanted to comment particularly on the feedback on the priorities, and I noticed that there's been some questionnaires circulated and some, feedback that has come. Susanna and I yesterday were at a People and Communities Committee meeting, and one of the frustrations that attendees expressed was the lack of responses when questionnaires are put out and not sort of getting the feedback of what is going to be done about what we've said. Is there a plan of doing something with that feedback, and what does that look like now we're going to communicate back to the people.
Thank you, Fanwell. That's such an important question. So for learning disabilities and autism, we have our health focus group, which is co-chaired by Wendy Scott, our LD lead, and Mark Conker, who's a person with a learning disability. And all the questions that are raised, all the feedback that we have is channeled through there. So they raise the questions to us, we take them away and we provide feedback. And there's a huge network in Suffolk of peer ambassadors that are supported by ACE, and they feed back individually through their organisation to people.
Follow up, Fanwell. Yes,
Yeah.
please do.
Yeah, thank you for that. I suppose, I mean, there is the responses to individuals, and some of the responses are quite individual in nature, but there's also the system-wide learning as well. So it's, creating mechanisms to respond to individuals and also to make sure that the whole system is learning from that feedback.
Yeah. I'll take that away and have a think about that, Fanwell, if I may, because I'm not sure that we have quite addressed that.
From a system
perspective. From a system
perspective.
perspective. Thank you.
I'll come to you, Andrew. Lisa, Fanwell, can you pick that up outside the meeting? That would let's do that. Andrew?
It's a separate point, if that's okay. So those of you who don't know me, I'm a consultant neurologist as well, and I specialise in epilepsy. And I spent probably my entire consultant career working very closely with people with learning disability and autism, because they are more likely to have epilepsy than people without. And I went in the Oliver McGowan training last year, and despite my long history of working with that population, I found the training utterly transformative, and I learned things that I had no idea were happening, about how to manage people with learning disability and autism. The preventable deaths of people with learning disability and autism is an inequality hiding in plain sight. And I would challenge any clinician working in Suffolk and North East Essex not to go to the Oliver McGowan training and learn something that potentially could be life-saving for a patient with learning disability and autism. So, I mean, Lisa and I work hand in glove on everything that we do, but in this one particularly, I'm 100% supportive of the work she's doing to develop this training, and would actually like the support of the rest of the board to get clinical staff particularly upskilled in learning disability and autism through the Oliver McGowan training. It is unquestionably the right thing to do to save lives.
Thank you, Andrew. And I saw a lot of nods around the table as you were suggesting that. So unless anybody is going to say, no, that's a bad idea, let's take it as a supported board action. But I notice I've got Frida and then Kath. So Frida?
Yeah, just in response to Andrew's comment, I mean, absolutely, it's so important. I've done it as well, and I certainly learned a lot after many years in general practice working with learning disabilities. The thing with primary care, I think Lisa knows, is the logistics of the course. And I think everyone's keen on doing it and wants to do it. That's what I've got. But the questions I get is how.
Okay, shall I just take Kath's and then I'll come back to you, Lisa, if I may. Kath?
Yeah, thank you. I wanted to echo Andrew in relation to the health inequalities experienced by people with learning disabilities and autistic people, many of whom touch standard NHS services. So I think it's about making sure that all of our colleagues, not just those in specialist areas, are capable of working with people and ensuring that the systems are in place to put reasonable adjustments in. People are dying because maybe they're not having their cancer screening. It might be they're dying because they're not having their immunisations. Some of it is fundamental care for people with learning disabilities and autistic people, and we need to own this at system level rather than at a single provider level, I would say. The other thing I just wanted to add, I'm just checking live data for NSFT, and our Oliver McGowan Part 1 training, we're at 94.7% compliant in NSFT. And just to make sure that isn't of a small number, it's 4,962 people eligible or required to do it, and 4,699 have completed it. So significant progress in doing that training, and very proud of that. But actually, it's what people do with that training is more important again, isn't it? Thank you.
Thank you, Kath. And let's note those numbers, Tom, in the minutes. So 4,000. Did you say 4,600 plus? Yeah.
4699 have completed out of 4962.
Very good. Thank you very much. So, Lisa, do you want to come back on those points? And I think there's strong support from board members for around the importance of this, but the big question seems to be how and communications.
Yes, and certainly the tier 1 training is e-learning, an e-learning package, and then an e-learning test, sorry. The tier 2 is a face-to-face for a whole day, and that's what is really difficult for practitioners. We were talking yesterday about how we can work with primary care in particular to support that. Maddie's got some ideas around splitting it down. So although it will be a whole day, it won't be one day. We'll be able to split the training down and look at different. It'd be really good to work with you, Frida, on that. Yeah.
I think that would be really effective, and I'd like to be part of that conversation.
Thank you, Lisa. Thank you, Frida. I'll go to Dave and then Nick. Go on, Dave.
Yeah, thank you, Lisa. And I agree, it's really important. I just wanted to confirm when we're talking about primary care that we're talking about dentistry and optometry as well. I'm aware at the moment that dental practitioners have no way of flagging a reasonable adjustment on their clinical system. And this is, as a system, we really need to address that. And I know NHS England, I think, have currently paused what they were working on, and
we haven't even started looking at dentistry, if I'm honest, David. I think it's a really important group, obviously. And yeah, maybe we need to start thinking about dentistry and optometry.
Really positive comments. Let me just stick with Peter, if I may, Nick, on the dentistry, then I'll come back to you.
Just on the dentistry, we have 2 specialist providers who look after patients from this cohort. So I think the first thing to do is we can check in with those 2 providers, CDS and CCS, exactly what their standards are. And that one of those is Cambridge Community Services, so they'll be part of the overall Oliver Gown, but we can pick that up as an action outside. I think the broader general dental community is a much bigger, more challenging, optician community, more challenging question.
Thank you, Peter. Nick?
Yeah, I had the privilege of recently meeting with Paula and Oliver's mum to talk about how we're addressing some of the training issues. But I think to the point, it's an area where, given that we're all doing level 2 training, I think we should open it up to anybody, because if it falls on a particular day when David's doing the clinic and everything else, he could come along to us and vice versa. So I think there's probably the HRDs from the system need to come together to open it up to everybody, and then effectively we've tripled the amount of opportunities that people have to attend the level 2, and also just a multidisciplinary and multi-agency approach to that could be very helpful within itself. Just the conversation you have over coffee about that kind of primary, secondary, it's easy for me to say, primary and secondary care interface for the care of people. So just to make that offer a suggestion.
Thank you, Nick. So, colleagues, Lisa, first of all, thank you for the update, which we obviously received and noted and very supportive of. But actually, the board's enthusiasm and passion for this is even bigger, isn't it? And I think the board is throwing you and colleagues the challenge here about actually growing this on an even bigger footprint. With that in mind, I'm just thinking of timeliness as well. Is an autumn update timely, or is there an interim point at which we could be receiving an update on that wider picture of uptake and engagement across the system and across the clinical base?
So I think an autumn update for the plans for training would be really good, because the current programme ends in September, and we are looking at now, we took a paper to exec yesterday on an approach we'd like to consider around a kind of an LD&A training academy, multi-agency across health and social care. Wendy's just pulling that proposal together, but that would be the first in England, which would be very exciting. And would really send a really strong message to our communities and to people with a learning disability and autistic people around our commitment to training. So Wendy, our LD lead, is just working that up. I can certainly bring an update to the board next time on training uptake.
Work in progress.
Yeah. Thank you.
But also, when you mentioned the training academy, I saw a lot of enthusiastic nods around the table. So can we take it again? There is board support for that direction of travel. Agreed. So an interim update at the next board meeting, if you like, work in progress, then a full autumn update, which will be part of your annual report as well. Everybody content? Sounds like a really exciting opportunity to make a difference to the real lives of real people, doesn't it? Thank you, Lisa. Thank you, colleagues. All done on that one? Agreed. Thank you. In which case, then, let's move on to the performance report. Richard, over to you.
Thanks, Chair. So as always in the pack, you'll see a brief outline against our main performance metrics. So just starting with the first slide on page 40, our performance committee that reports to the board last met on the 11th of February. So it meets every 2 months. You'll see there the main areas of focus was the winter debrief. So really looking at some of the lessons learned from the kind of the heart of the winter period. And you'll see the main messages there, which are now flowing into already planning for next winter. We've also looked on a quarterly basis at our joint forward plan performance metrics. So they're the metrics that we just talked about in the previous item. And you'll see there the areas where we're doing particularly well and some of the areas that we're not doing so well on. And I'm happy to cover that in any questions. We also go through a much more detailed pack than you see here on the performance itself in much more detail. And again, I'll cover some of those in a second in terms of more of an update on where we're at with some of the main metrics. We also talked around the sustainability review that we'll be talking about in the board meeting later. And we got an update on the vaccination position, which we were doing particularly well at that point in time in February. So just to briefly go through, Chair, as we've got a little more time, I think, this time, just to talk around some of the main elements of those 4 key themes: UEC, elective, cancer and mental health. So on UEC, I think following that period of extreme pressure during winter, UEC performance has started to improve, not where we want it to be, but it is getting better than it was. So you'll see in the pack, sticking first with the 4-hour standard, that we were just shy of 74% as a collective across SNE at the end of February. That's against the national standard of 78%. Both trusts have continued to improve, and both trusts are absolutely aiming to achieve the 78% target by the end of March, so effectively the end of this week, early next. West Suffolk in particular are doing well. They are the highest performing now in the region at 86.9%. That was at the 20th of March. And ESNEFT were in 4th place regionally at just shy of 77%. So again, comparatively doing well, but obviously we want to go further than that. Similarly, on ambulance handovers, we're not where we want to be, but it's improved significantly from December and January. So we are now, just shy on the 30 minutes, which is positive. And 12-hour ED waits, we're still obviously aiming to get down to none, but we have improved down to 9.8% since this report. Turning to elective, the position has improved further since these slides were done. So you remember, obviously, we're always about 6 to 8 weeks behind on the data that goes into this pack. So at the moment, both trusts are expecting no patient breaches for capacity reasons and to hit that standard against 65 weeks by the end of March, which is really positive given where we were earlier in the year. ESNEFT is also predicting that they will achieve the 95% target against diagnostics for the end of March, which is positive. And West Suffolk are making improvements against both some of the Eurogynae challenges that they've got within elective, which is the main cohort that was causing the challenge against 65 weeks, and have also started to improve against their recovery plan around diagnostics. On cancer, it's an improving position. So in the pack, you'll see we did dip during the month that the data was based on, but the invalidated position for February for both trusts now showed on 28-day faster diagnosis. So that's a 77% target. Both trusts are expecting to hit that. And on 62-day standard, which is 70% seen, Again, there is strong indications that by the end of the month we should be there or thereabouts. So an improving position, dipped in the month of January, but back moving towards recovery of both those standards. And just to point out two things on that, the main challenge, you will I'm sure agree, where Suffolk on cancer has been skin and breast. Given the scale of the number of patients within those two, any dip in performance for either of those two specialties has a significant impact on overall performance. Both of those are now seeing a significant improvement. Indeed, on skin, over 90% of patients on a skin pathway are now being seen within 28 days. And also at ESNEFT, I think Nick would agree, one of our main challenge areas has been lower GI. I'm really pleased to say, after a lot of concerted effort across the partnership, we're nearly at 60%, which is the national standard. And that's a huge turnaround when we're in, at some points, in the low 20s. So that's really good. And hopefully we will be able to sustain that. And then just finally on mental health, just to point out, excuse me, a couple where we're doing well. We're now the second highest nationally on people with a serious mental illness having their annual health check, which is great. Again, we want to go further. That's one of our ambitions, to get even higher than the national expectation. And secondly, around perinatal access, so access to those services, we're in the top 5 in the country, which is positive. There's always a flip side. So the areas where we are struggling, it's the same as I've reported previously. So on dementia diagnosis, North East Essex is doing really well at that alliance level. So we're ahead of trajectory. In both of our 2 Suffolk areas, we remain below target. And we've had lots of conversations as an exec and a board previously on that. A lot of this now relies on, which we are doing working with EPUT, on some of the waiting list management that we've got. We've got too long a waits around dementia, and we've got some recovery plan work that we're now looking at. And then the second one is, again, unfortunately, as I've talked about previously, and Moira and I are working on with others, is out of area placements in North East Essex. EPUT is particularly still struggling with the number of out of areas. So effectively patients that are being supported, treated out of the county of Essex. We've got a significant number of patients across the whole of the county of Essex that we've got loads of recovery work going on, a focus group working on, but at the moment we're not seeing the impact that we would hope for. So I'll leave it at that point, Chair, and happy to open it up to questions. What I should say is Maddie asked me to say, as she's away today, that if there's any questions related to the primary care part, she's more than happy to follow up if Laura and Peter can't answer any specifics.
Richard, thank you very much. So in summary, Richard, some great progress, which we absolutely mustn't belittle. So moving forward in many areas, but still work to do across a number of areas, as you've highlighted. So let me first go to Kath.
Yeah, thank you. I thought I'd bring a personal experience to light. So my mother-in-law was brought into A&E at ESNEFT in mid-January. Amazing response from the ambulance trust, was with us within 15 minutes or so, brought into the emergency department, offloaded immediately, in A&E, assessed, cared for. She didn't meet the 4-hour standard. Despite that, she had exceptional care in an exceptional environment. So I just think it's really important that we remember the standards are numbers and there's care behind that, and we could shove people through a system within 4 hours. That doesn't mean that's good care. So I just think it's important that we remember this is a clinical standard, not a target, and actually there's more to a number. There's people behind this and good care from our staff. So thank you.
Thanks for that personal example, Kath. Well articulated. Richard, did you want to respond to that?
No, I think that's absolutely makes sense, and pleased that your mum, I know Noah Fine, has had good care within ESNEFT.
Okay, thank you. Thank you, Kath. Elaine?
Yes, so it's really good to hear the areas of progress, actually. That's really uplifting. One area I did identify in the report where there was high risk called out was around the primary care appointments within 2 weeks. And I know you said actually Maddie's not here, but I was wondering if it is possible to perhaps just expand a little bit on that and what's been done about it.
I can't, I'm afraid, because it's not my area. But Maddie's more than happy to follow up in writing. And she's also suggested actually that it would be useful maybe if there's a session with the NEMs and the primary care leads on the board, maybe just more broadly to have a conversation around primary care performance, kind of an understanding of what's happening and where we might want to focus our efforts, if that's helpful.
Yeah, I think that'd be really helpful. Thank you.
So could we take that as a follow-up outside the meeting for the purpose of the minutes, Tom? Thank you very much. Thank you, Elaine. Are you okay if I hold you? I'll go to Moira first. Yeah, go on, Moira.
Thank you. Would echo what Richard's saying about the work in Essex on out-of-area placements. I think the other thing is that nationally the physical checks for people with mental illness has been deprioritised, but I think it's really important from an equity perspective and reflecting some of the comments about early death for people with learning disabilities absolutely also applies to people with mental illness, and keeping an eye on that metric and the equality impact of that metric is going to be really important.
Thank you. Richard?
I'd absolutely agree with that. So you'll note in the JFP, the Joint Forward Plan, we did retain that. So even though it's, as you've said, more, it's not a national metric that we're being held accountable for, we felt it was really important for the reasons you've said to maintain our performance on that. And I'm really pleased. Huge thanks to our primary care colleagues and both EPUT and NSFT for the work that they've continued to do, as well as the voluntary care sector. Just to shout out to Suffolk Users Forum, who does a huge amount of work in Suffolk to support that cohort.
Let me just check with you, and is it on this subject? In which case, I'll bring you in. Nick, is it also on this subject as well? So you and Nick, and then Ed, I'll come to you.
Yeah, it's just a question, Richard. I mean, clearly carrying out the health checks is important, but the thing that's most important is the actions that are then taken to address that. Do we have any data on the effectiveness of the checks?
I don't think so, but let me ask Alex Royan in the team. So that's partly why in Suffolk we've commissioned Suffolk Users Forum to do the ongoing support, because as you've said, it's a bit like the point that Kath made around that's a target, a number, but actually what does it mean in terms of the care that's provided? So Suffolk Users Forum provide a wraparound support to those individuals to help them access the care that the plan suggests. So it may well be, actually, I'll speak to the team there, because at least they'll have a proxy around the kind of things that's happening.
Yeah, thanks, Richard. Tom, again, another action there for a follow-up, if you would be so kind. Nick?
So it was a more kind of general point, really, is in terms of, and it relates to some of the points that have been made. I think we'd all accept that the national standards deliver fairly mediocre ambition, and don't always measure what's really important. So if you use the 62-day standard for cancer specifically, there are 4 tumour sites where prognosis becomes significantly more concerning after 62 days, and a huge number that don't. And the huge number that don't are the numbers that we chased in order to deliver an average. So I'm just wondering whether or not anybody's picking up nationally that there's more of an appetite to talk about very localised ambition, or do we as a board want to have some conversations into the next financial year about what really matters to the people that we serve? So to get poor care in less than 4 hours is significantly worse than getting great care at 4 hours and 13 minutes. And the cancer standards, again, there's 4 tumour sites where prognosis deteriorates significantly after 50 days. Should we not be concentrating on 100% for those and be more relaxed about maybe some of the others? So given the resource constraints. So I'm just wondering whether or not we as a board would welcome that conversation. For our standard, for me as a board, what we should measure is the number of people who pitch up in A&E in the first place because we haven't been able to provide the right care in the community. So a standard of attendances per 100,000 people over 75 might be more significant for us as a board, an integrated board, than what actually happens once they get over the threshold of their ED department in Colchester, Bury St Edmunds, or in Ipswich. So just a question really about our appetite for that conversation with our patients, with our staff, with the public, to set some ambitions that are pertinent to the people that we serve, rather than delivering against a national standard.
Yeah, and there were a number of nods around the table as you were speaking there, Nick. There's an Einstein quote, isn't there? Not everything that can be counted counts, and I think we've got to make sure we're counting the right things. No, well, I should have said a Nick Hume quotation, shouldn't I? Obviously. Let me just go to Elaine, because I know it's on this subject, and I think the answer is going to be yes, we are up for the discussion. But let's see what Elaine says.
Yes, I think that's a good idea. And I think it's like earlier on, we were talking about metrics. Obviously, some of those were put in place a long time ago. And I think now that we're working as a system, that makes perfect sense for us to think about what's really important for the population. What are the things that we can measure that matter to the population? And also what are the measures that matter that we can focus on as a system? So I think the time is really good to do that. So yes, I wholeheartedly agree.
Thank you, Elaine, for that. And there may be this may be a useful subject for a development agenda item, but I'm just very conscious I've been holding Ed for a long time, but this subject is developing. Let me go to Richard and then Dave, and then I must go to Ed.
Thanks, Jess. Just briefly going back to Nick, to break that down, I think with the new transitional team coming into NHS England, there is an opportunity to influence through respective roles, thinking around what those kind of key metrics should be. I think in relation, obviously, to the 10-year plan, I'd expect that being where in the working groups that I know some colleagues are part of is where it would be helpful to kind of use that as an influence. I also think, I know you know this, Nick, we will not be able to deviate away from the national constitutional standards. However, I do think there's an opportunity with the refresh that we talked about earlier of the JFP to think, and taking Elaine's point, to think again afresh around, okay, so we have to meet those national standards, but the way we go about doing that is for us to determine. And secondly, we can put other things in. So for instance, on the 62-day and the 28-day FDS, yes, we absolutely need to meet the national expectation, but we've got wriggle room on 78 to 100%, for instance. So if we want to go harder on those 4 tumour sites, let's do it. That's within our gift to do. We don't need to wait for national to tell us.
Yeah. So I think it's a really good point, Richard, and I've had some very initial conversations with the transitional team about this, but I think the point is we have to see the national standards as the bare minimum to achieve, not the ambition. So the ambition should be more than that, and it may be that we're looking at different standards. It's something that we've talked about for years. I just think, my pet one, which is that nobody gets diagnosed in A&E for cancer because our screening programs work, and now that will always happen to some extent, but that should be something that we really work towards in terms of early diagnosis. And then how do we link in some of our health inequalities work, and what sort of standards and ambition do we set towards that as well? Thank you. I won't go on.
No,
I'll be here
don't
all
worry.
morning.
This is a really important subject, isn't it? There is another side to the Einstein quote, isn't there, as well, that not everything that counts can be counted. So let's schedule this for a future agenda board discussion. Dave, and then on to Ed.
Yeah, just very quickly, absolutely welcome primary care having an agenda to discuss performance activity. I wonder whether the board would welcome the newly formed GP executive to come along and present at the same time, to perhaps highlight raise the awareness of their role there as well.
Okay, thank you. Thank you very much. Really useful. And Ed, I'm so sorry for holding you so long.
I mean, just on the primary care, I'm pretty confident there's going to be more scrutiny on primary care performance at practice level in the kind of the newly formed Department of Health and Social Care. So I think it is important that we get ahead of this in terms of how we scrutinise it ourselves. My question was to Peter. So this is a really good news story in dental activity. So target 64,000 treatments, delivery 92,000. So we've gone way beyond the target, which is kind of really important message to our community. I guess the question now is, because there's such a difference, is the target appropriately stretching? Can we lift the bar up again? Would be my question.
Can we get it even bigger, Peter?
Yeah, I mean, there's 2 answers to that. I mean, the first thing is that's what we're. Yeah, yes and no. No, the 2 answers. But we're already doing the urgent care one, so that there's another sort of 15,000 worth of patient appointments that we are in the process of commissioning with practices. I think the next question is, this is, a bit of a question for us as an ICB, isn't it? I mean, how much we identified shortage areas, how much energy and capacity we put into following through the procurement, because that's what we need to procure the extra capacity we need in tendering in Bury St Edmunds and Leiston. We now need to get to a point where we're putting those pounds out there, but that's going to require capacity as a team and beginning projects now that will take 12 months from conception to completion. So there's some tactical judgments for us there. So that'd be a two parts to my answer, Ed, if that helps. And obviously with the University of Suffolk, as they fully recruit, they are seeing more and more patients every week at the moment. So that's the other part of that story.
Go on, Ed.
Yeah, my judgment would be let's get on with it.
Yeah. And again, nods of support around the board for that sentiment. So that was a really useful discussion. I won't try and summarise every word, but we're noting the progress. We're noting there's work in progress and still performance improvements to be delivered. But we're also noting the need for a substantive debate, probably in board development and then formally around the public board, about, if you like, counting what matters. I'll summarise it as briefly as that, if that's acceptable. Everybody content with that? Lovely, thank you very much. In which case, item 12, the finance report. Howard, please.
Thank you, Chair. So just my usual reminder to the board of the following, that when I use the word system in this context, I'm talking about the formal ICS partners. So that's the ICB, Essex, East and West Suffolk. With respect to this financial year, that's 2024-25, the system has an approved balanced financial plan in line with the £2.6 billion of funding allocations that we have. The board will recall that West Suffolk went off plan by £11 million during 24-25, and following mitigating actions, the ICB approved a revised plan deficit for West Suffolk of £23.9 million, offset by revised surpluses at the ICB, Essex and East at the January board. I can report that all organisations and therefore the system are fully on track to deliver the revenue and capital plans for this financial year. And in addition, the ICB is on track to deliver against the mental health investment standard, the running cost allowance, and is set to over-deliver on its cost improvement plan by 109%, which is excellent performance from the ICB. With respect to 2025-26, as has already been trailed, there's been a huge amount of focus over the last few weeks, very much focused on planning, and given the national context, it's been, I would say, more complex than usual. But to that end, I can report that we've reached a position where we can present to the ICB board tomorrow evening a system financially balanced plan. This will still include a significant deficit at West Suffolk Foundation Trust, and with some significant risks that will require rapid focus really in order to deliver those mitigations as we get into the next financial year. The Finance and Performance Committee will be reviewing that plan for assurance in the early afternoon tomorrow, prior to the presentation at board at 6 o'clock tomorrow evening. I'll stop there, Chair, but happy to take any questions.
Thank you, Howard, and thank you to all for the great progress. This is a team game after all, so thank you to everybody who's contributed to that position. Any questions for Howard? Otherwise, we're asked to receive a note. Duly received and noted. Thank you all. Thank you, Howard. Item 13, ICP update. Susanna.
Okay, thank you, Chair. So the last time I was here at the meeting of the Integrated Care Board, presented our Integrated Care Strategy Future Shift. Since that date, we've submitted that strategy into the national engagement around Change NHS, presented it at a number of national forums, including 2 different meetings of the convened by the King's Fund, and also shared it through the EPIC collaboration of 6 universities across the east of England as well. Within the system, we've been working on making Future Shift even more accessible to everybody who's interested, with a number of different formats available, including now some films which explore how delivery is already underway of working in a very different way across our ICS. So those are on our ICS website. And also there are numerous work streams across all sorts of different areas in terms of action across different ICS partners in relation to the strategy. The ICP, we've now announced the date, as Ed updated, for our 2025 Expo event. This is a really important opportunity for the broadest range of partners in our ICS to come together and to build those relationships and maintain those relationships, which is so important in our system. Future Shift will be the theme of Expo 2025, and in particular this year we're going to be focusing on innovation and technology, with a number of industry partners as well contributing to the programme. One of the key features of our Expo event will be our ICS Awards ceremony. So we've also now launched this year's ICS Awards, again around the themes of the Future Shift. So all of the details are available on our ICS website, and it will be our People and Communities Assembly who will be making up the membership of our judging panels. So all of the awards are judged by people from the perspective of relevant lived experience. On the theme of our People and Communities Assembly, they met yesterday, as Manuel already mentioned, in West Suffolk. So we did have a focus on West Suffolk in particular. It was a hybrid meeting attended by a large number of people on site, but also people joining remotely as well. And it continued on some of the key themes which are now being brought forward by the Assembly around the use of plain English, tackling use of acronyms, inclusive communication. And yesterday afternoon, we also delivered co-production training to a number of people at West Suffolk College as well. The ICP has recently supported a meeting with Suffolk Care Association, working in particular with Suffolk County Council and local social care providers, looking at sustainability of social care providers. And there will be a report from that meeting, which will be on the agenda for the next ICP committee. So the next ICP committee meeting is on Friday, the 11th of April. There will be a number of important agenda items, including we will have completed our first suite of impact reports about the collective impact across our ICS of our anchor organisations, NHS anchor organisations, so looking at the different anchor pillars. Also, we met last week with colleagues from CQC, Lisa and I and some other colleagues from across system partners to review our system dashboards, and pulled out a number of really interesting trends from the data there. So that will be a focus for the next meeting, as well as, of course, some of the issues around risk at the moment and risk issues being experienced across different ICS partners. Finally, we're shortly going to be announcing dates for this year's system learning programme, which will be a continuation around uncomfortable truths. So as we agreed a previous date, that we would continue the work around uncomfortable truths for the time being, but also very importantly, Andrew, Kelso and I have been working together on plans for a programme around antimicrobial resistance as well. So we're just trying to pin down the initial date for that, because we'd like to have some quite high profile input for that. But it's a really important topic to be discussed across system going forward. Thank you.
Susanna, thank you very much. Lots of work there. Fanwell?
Thank you, Chair. Thank you, Suzanne. Just to follow on that, one of the questions I think that is emerging from some of our wider partners is around the subject that Ed gave a brief on, in terms of the changes that are sort of impending and what's going to happen. And yesterday, Susanna did give a briefing to the meeting about what we know so far. But there's clearly, I think, a need for more information from particularly some of the delivery partners as to what is going to happen to the work that we are delivering collaboratively. So I suppose as soon as we are clear, it would be good to sort of move in as quickly as we can to provide whatever assurance we can to delivery partners about what the future is going to look like.
I think that's a very fair question, Fanwell, isn't it? And this being a moving feast across so many different agendas. But Susanna, do you want to respond to that?
I think it's a really important point, and sometimes at the moment with so many things changing in so many different sectors across the ICS, people have said to me, you know, should we wait before we have a meeting? I think it's actually more important that we keep talking and working together across sectors at the moment, because things are changing so quickly, and the most important thing is that we support one another, as Ed said earlier on, that kind of compassion, kindness, but also understanding, really, and keeping pace with those changes is really important across system partners at the moment.
And keep the board will be kept updated. As soon as we know something, board members will know. Okay, any other questions for Susanna? Otherwise noted. Look forward to next event on the 11th of April. Noted, thank you very much, in which case item 14, the governance handbook update. Amanda.
Thank you very much, Chair. So as we approach our 3-year anniversary at the 1st of July, as a board, probably about 6 months ago now, we committed to do a bit of a refresh and just check that our governance arrangements were fit for purpose. So Tom commenced a review with colleagues within the ICB and the wider board, probably now October, November, and that piece of work has now concluded with a recommendation to board this morning. And in terms of doing so, we basically did a bit of a light touch. We took stock of our current committees, and we have refreshed and reviewed and really simplified, hopefully, the governance pertaining to how, as a board, we work. So prior to the review, we had 26 committees that reported into board. Through this piece of work, we have reviewed and reduced that so that we have now, or proposing that we have 10 committees that report into our board. And in doing so, we have taken stock, along with our non-executive members, of how we align their roles and responsibilities most appropriately to the emerging governance. There are two main changes, I think, that we would be wanting to recommend to board. The first is a change from Finance Committee to Finance, Performance and Workforce, so that we as a board have the triangulation to make sure everything that we are doing with regards to our money relates to our transformation agenda and, importantly, our workforce. So that is something that is significantly different to our current arrangements. And the second recommendation is taking a different approach to our SOAC committee and changing that from a Strategic Oversight Assurance Committee to Strategic Commissioning Committee. So those two committees are really the main changes in terms of how we currently work as a board. We have updated all of the terms of reference pertaining to all of our committees, and they have been updated and refreshed and incorporated into the handbook, which is attached to the board paper. So, Chair, I'm recommending to the board that we accept the new arrangements, that we have 10 committees, not 26 reporting to board, and that we have a Strategic Commissioning Committee and a Workforce, Finance and Performance Committee.
Thank you, Amanda. And Amanda, would you like to say, I know you won't necessarily know the answer to this in black and white terms, but are we expecting, do we think that we're going to have to do this review again at some point in the near future?
Absolutely, without question. But what we don't know is what we don't know. We know that there is going to be change afoot. We know there will be significant ICB and wider change. And once we know the future plan, then of course, as a board, we will be committed to making sure that we have proper, fit for purpose governance arrangements. So yes, in short, lots of work to be done once we know what the plan is.
So would it be fair to say that the board should, if the board is approving today, that it's approving but noting that it's effectively a work in progress in a way, and we'll be revisiting this in a similar discussion to the JFP discussion with Richard earlier. Yes. It'll be back before us before too long. Okay, good. Ed?
Yeah, I've got no issue with the paper at all. I'm just thinking about the likely sequence of events over the coming months in terms of ICBs. So, and potential for more joint governance, etc., etc. So we'll just need to be live to this as things play through.
And it may be thinking out loud on that point, Ed, that we do bring an update to future every board meeting just to check where we are, check that we may need to tweak governance as we move forward. I think it's a very live issue.
It's a new standing item, effectively. Yeah. Tom? Did you capture that one? Yep. Thank you very much. So, with those caveats and with the principal changes here being around finance to finance, performance and workforce, and SOAC to strategic commissioning, but noting that this is effectively a work in progress, or it's not a working draft, because if we approve it today, we're approving it, but noting that we're going to visit this again in the very near future. So with that caveat, are we happy to approve? Approved. Lovely. Thank you very much, Amanda. I'm going to stick with you, Amanda, for the item 15 on the BAF, please.
Thank you very much, Chair. So here we have our updated board assurance framework reflecting our main strategic risks. And as board colleagues will have read, we currently have 14, which was the same number of risks as last time. But since we last met as a board, all of those individual risks have been updated and reviewed by the relevant director, and indeed they have been scrutinised by the relevant committee between last time and today. We heard earlier on from Lisa that the action pertaining to mental health has been updated and reflected in the current BAF. We may hear a little bit from Howard in a moment regarding the finance risk, which was updated and referenced at last week's committee. And indeed, we have an emerging risk that was alluded to at the very beginning of our board meeting. And now we know there is change afoot. By the time we receive our next board assurance framework as a board, there will be a new entry to reflect the imminent changes regarding our 50% running cost reduction. And hopefully by then, we may know a little bit more, and then we can be more confident as a board how we manage that going forward. So a proposal for the board to note that a new item will go into the BAF around reorganisation and change and the risks associated with that. Absolutely. Okay. Howard, did you want to comment on the finance item, please? You may have something to add there. Nothing to add? No? Okay. Happy with that? Good. Any questions, Lisa?
Thank you. I just wanted to give a verbal update on risk 32, which is the System Children and Young People Services risk around SEND. I just wanted to update the board. So in Suffolk, following inspection, Essex is still to be inspected. We obviously are working under an improvement notice at the moment with an improvement plan and an improvement board in place. And as part of that regime of working in that way, we had a deep dive from Department for Education and NHS England recently, which was a 3-week deep dive into our progress in how we are supporting children and young people in their preparing for adulthood. So how does healthcare and education wrap around children and young people during any transition? And we often think of transition as being transition to adulthood, but it's much more extensive than that. It's how in early years are we supporting children to transition from nursery into reception if they have complex needs, or as part of any transition in their life, how do we all wrap around that child? Because we know for children with complex health needs, the risk during education transition or home transition is huge and puts a risk for their health outcomes. So the DFE and NHSC, they visited 3 schools. They visited a college, a specialist education school and a secondary school in Suffolk, and they met with our Parent Carer Forum and 5 other parents. And I think for health, the key messages were that there is some great, isolated, brilliant practice, but we have some work to do to understand how our young people experience health transition. We're not often routinely measuring and understanding and asking young people how they experience transition. Some of the young people described falling off a cliff edge, and even when they had significant cardiac ill health, were being re-referred back to the GP and then re-referred back into adult cardiology. Now we know there's nice guidelines. There's been a number of reports. We've been talking about this for years, and I guess my ask is for us all to examine our processes in transition, how we support young people in transition, and how do we know if we're doing a good job? What are our young people telling us, and how do we want to improve? Because this is going to be a key area for us in health. Thank you.
Thank you, Lisa. Quick question from me. So how would you like the board to show its support for that?
So when we receive the report from DfE and NHSE, I'd like to bring that. We are developing a PFA strategy in Suffolk and establishing a PFA board. I think once we've got the report, I'll bring that, and then I'll update it with the PFA strategy when we get that.
Okay. Any idea on timeline for that?
The PFA strategy we're looking to complete over the next 3 or 4 months. It's got to be obviously it's got to be co-produced, which means it'll take a little longer, but we're looking at about 4-month timeline.
Okay, so back end of summer,
Yeah,
maybe.
Yes.
Yeah.
And we'll have the report next board. So
For the
I'll bring
next
that
board. Okay, so
yeah.
report for the next board, Tom, and then back end of summer for the next steps. Okay. Thank you for that update. A really important subject matter, as Lisa has described, and has been for a long while. Andrew.
2 things, if I might, Chair. First of all, to come back on Lisa. As you know, within this system, we are putting a lot of focus into interface and making interface work better. And primarily that is between primary care and secondary care, and primary care and mental health, specialist mental health providers. But we also have to consider the importance of interface within providers and within pathways of care as well. And I think transition probably is a really good example of internal interface that we could apply some thinking from other work we're doing into that as well. And I agree, transition is in all pathways is something that we are long overdue improving on. I actually think we're probably overcomplicated, so keen to work together on that. The point I was going to make, though, is that as we probably said before in boards, in quality committee, we're spending some time going through some of our key quality risks related to the BAF. And in February, we had a deep dive into cancer, looking particularly at cancer services. We received a fantastic set of presentations from Suffolk and ESNEFT, detailing some incredible work happening in cancer that they've just been fairly quietly getting on with, a lot of which exhibits the best to future shift. We're taking that through quality committee, reporting it back, and then deciding as quality committee what we need to do with that learning from there. But we would expect to be reviewing risk 19, which is system cancer standards, as a result of that. So if there's an update in that, that's the heritage of that.
Okay, so to come. Yeah, lovely. Thank you for that update. Very important work. Any other questions or points on the board assurance framework and the plan going forward? Noted and approved as currently is, but I think, Amanda, we're expecting to see some significant changes. Yeah. Okay, thank you. Item 16, committee minutes and highlight reports. There are 6 before you in the pack. First of all, are there any chairs or representatives of committees who would like to flag anything specific from those 6 highlight reports and minutes that you have before you? No additional flags. Are there any questions for any of those chairs or committee members that you would like to raise? Otherwise, we are simply asked to receive and note. Duly received and noted. Thank you very much. In which case, item 17, the attendance log, again, simply to receive and note, unless there are any questions. Duly received. Thank you. Any other business? Now, none has been flagged to me prior, but I'm just looking around the table, so wave at me now if you have any other business you'd like to raise. None raised. Thank you very much. In which case, that takes us on to questions from members of the public. So we have 10 minutes for this item. We have a total of 9 questions. We'll see how many we can get through in the 10 minutes. Simon, am I coming to you to read out the question and then we'll go to the appropriate person for the answer? Are you going to start with the question about cardinal medical practice from Albert Horn?
Yes, I will, yes. So that question is, I attended a meeting with my MP a short while ago where he said that a further site for cardinal medical practice had been identified and that work would start this year. I've since heard from the practice that this is now not going ahead. And while respecting any commercial sensitivity considerations, would the ICB please clarify which steps, if any, are being taken to support their joint forward plan, in particular the vision to deliver the best possible health outcomes for every one of the 1 million people living in Suffolk and North East Essex, by supporting this good-rated practice in their endeavours to deliver the best possible health outcomes for every one of their 30,000 patients.
Do you deal with this one?
Okay, it's a very thorough question, isn't it? So I can confirm there are a couple of options that are in flight at the moment we're pursuing. We can't say anything more due to commercial sensitivities, but there's definitely a potential way forward for Cardinal, and we're actively pursuing that.
Okay, thank you. And then Simon, shall we do the next one, the question about RTT from David Miller?
Indeed, and the question is, what is the statistical distribution of referral to treatment, RTT, times for patients diagnosed with Parkinson's-related conditions in 2023 and 2024, and how does this distribution compare to the target of 18 weeks set out in the Board Assurance Framework, January 2025, strategic risk number 3?
And Richard, I think you're going to deal with this one.
Yeah, thank you for the question. So I've passed that on to our analytical team who's working on it now. It's not a straightforward, quick job, but they are pulling the data together, working with the 2 trusts. So we're happy to speak to David offline and get that through to him.
Okay, thank you. And then Simon, we've got 4 questions from Mr. Dooley. I think the first one is regarding updates and future planning.
Yes, the first one is, now that NHS England has been abolished, isn't it about time that you informed the public that there is no National Health Service in England, as your existence demonstrates? There are 42 fragmented so-called integrated care systems operating on a fixed and inadequate budget to address the health needs of those covered by SNE.
And Ed?
Thank you, Mr. Dooley. I'm glad you raised that point, actually, because when the news broke around NHS England, we had a number of members of the public contacting us, thinking that the NHS was being abolished. So it's, to be really clear, this is an organisation within the NHS. It's not the NHS itself. What's happening is that the government are returning us to a footing that we had prior to 2012. So prior to 2012, we had the Department of Health, which oversaw the operation of the NHS. With the Lansley reforms, NHS England was created to create an agency that wasn't directly under any political influence. And now we're returning to a situation where you've got the Department of Health and Social Care with full oversight of the NHS. So the NHS is not being abolished. This is a reconfiguration to make the oversight clearer and more accountable. So I think it's important to get that point across.
Okay, thank you. Back to you, Simon.
Okay, the second question is, I've wondered why your agendas always include an item, declaration of interests, and to believe in the integrity of all board members to behave appropriately. However, do you agree with me that if you should always act properly regarding DOI, why isn't this extended to the likes of Varzi, who didn't declare his $500,000 shares interest in an American private health company, etc., when writing his report allegedly as an independent person, nor to the likes of Streeting, who has accepted, along with other current ministers, hundreds of thousands of pounds of donations from private health companies. Whatever happened to the Nolan principles of conduct in public office?
And Ed, back to you.
I'm not in a position to comment on Secretary of State or Lord Darcy. I think for this board, we all adhere to the Nolan principles, and we have a fit and proper person test where appointments are being made. So, yeah.
Okay, thank you. Simon, back to you.
Okay, the third question then is for Mr. Dooley. What is your response to the prospect of you inviting representatives of private companies onto your board, particularly in light of question 2?
And Ed?
Our current and any future board membership will comprise colleagues and individuals who have significant relevant experience and who can offer value to providing services to people across Suffolk and North East Essex.
Thank you. And Simon, back to you again.
Okay, number 4 then from Anthony Dooley. I raised some time ago the issue of national screening for prostate cancer. I declare an interest as someone diagnosed and treated for such. Given that a much more sophisticated testing tool has been developed, would Richard update us on his thinking about whether there now should be a national testing programme for, say, all men at 50, or given the replacement of NHS with ICSs in England, whether SNE would commission such a screening locally?
Thank you. And Richard?
Thanks, Anthony. So just for the background for the board, there is currently no, which Anthony's alluding to, there is no national screening programme for prostate cancer. And there are mixed views clinically, nationally, and elsewhere around the efficacy of that. At the moment, the main test for it is the prostate-specific antigen or PSA blood test, which at the moment there are mixed views around its efficacy if you did roll that specific PSA test out on a screening basis. As Anthony's alluding to, there are actually several exciting new developments around prostate cancer, around testing. All of those are still, though, at the pilot stage, is my understanding. So none of them have actually gone through and been approved. Having said that, locally, we've done an initial pilot in North East Essex with an organisation called CHAPS, using the PSA test, which is the one that we currently can use, where we've used our population health management infrastructure to really focus on those gentlemen who are most at risk of potentially developing prostate cancer. And we're currently looking at the outcomes of that. So it's not a broad brush screening program, it's a targeted screening at a cohort of men that are most at risk of prostate cancer. I think that's something on a personal basis I'm quite interested in exploring while we're still waiting for the outcome of these national testing tools. Last thing I'd say, and Anthony's probably aware, is there is a huge nationally backed trial now called Transform, which is involving hundreds of thousands of men, which launched last year. And that will compare the most promising tests and hopefully provide definitive evidence once and for all on whether there should be a national rollout of a screening programme. But as I say, locally, we are looking at the pilot work that we've done and whether we do something more targeted around that screening at men at risk.
Okay, thank you. And back to you, Simon.
Okay, the 5th question from Anthony Dooley. You will be aware of a study by Oxford University on the effect of the employment of PAs, and given a recent coroner's court conclusion that a death was attributable to the failure of a PA to diagnose a situation properly, surely Dr. Kelso now would feel obliged to replace the label attached to PAs as respected professionals to something more appropriate and accurate in the interests of patients. Perhaps the board can update us on the pilot at the 2 Ipswich GP practices in relation to the employment of these non-doctors.
And Andrew.
Thank you for the question. It was a very interesting paper, wasn't it? I also was interested in it. It was commissioned by Gillian Leng, who is conducting the review into Physicians Associates nationally. It will form part of the evidence base towards that review. There aren't any pilots of employment of Physicians Associates in Suffolk and North East Essex, and Physicians Associates remain valued and respected members of the healthcare teams in Suffolk and North East Essex.
Okay, thank you. And Simon, if I could just hold you there for a moment, because we are actually out of time, but could I just check if there are any questions from members of the public in the audience? And we've got at least 3. So let's try and deal with those. What we'll do then with the remainder of the questions submitted in advance, we'll deal with them as written answers. But let's see. I saw 3 hands raised. So if you could introduce yourself and ask your question, whether we'll be able to answer it today or not is another matter. But if not, we'll do a written answer. So, gentleman in the front row first.
Of course, thank you. My name is Lucas Polydisard. I'm a regional organiser for Unison. Thank you, Professor Pope and Dr. Garrett, for your response to my letter last month about the commissioning of patient transport services across the ICB. I wanted to know a bit more about what the ICB's plan and process is for the commissioning of non-emergency patient transport. What plans, if any, are there to involve unions, and what is the present timeline for the decision, considering the delay in the extension of the contracts?
Okay. Any comment on that initially, or is that a written response? Do you want to go with it, Howard? Yeah. Okay.
I mean, I guess in terms of the plans, so important to note, first of all, there are 2 contracts currently held, ending on the 31st of March 2026. The ICB made a decision to bring those into a single contract covering the whole of Suffolk, North East Essex, to ensure equality of access and also to seek improvements in service. The healthcare services regulations 2023 basically give us a legal requirement that given the nature of the contract being a healthcare contract and also the fact that the value would exceed that considerable change threshold meant that we have to go to a competitive tender. I obviously can't say much more about the competitive tender given its nature, but we're close to concluding that process now. Thank you.
Okay, thank you, Howard. And then if you could introduce yourself.
Hello, my name's Becky. Following on from what Lucas said, I'm a non-emergency patient transport worker for the East of England Ambulance Service. East currently provide PTS services in North East Essex. And we all know that private PTS companies do regularly undercut the ambulance service on staff terms and conditions, training, supports, and this has a massive knock-on effect on patient care in some extreme cases, and they are extreme, even to the cost of patient lives. How is the ICB building a tender specification that the ambulance service can bid on and win as a high quality provider rather than being cut out as too high a cost?
Okay, thank you. Howard, any more to add to that?
I don't think I can add to what I've just said really. Yeah, thank you.
But again, happy that we give a written response after due consideration to both your questions. So we'll take that as an action as well. Thank you. And we had a gentleman in the middle row there. Yes. Just hang on 1 second. I think your microphone needs to go on.
Okay, can you hear me now?
Yeah, got you now.
Oh, Andy Benson from Suffolk, Keeper NHS Public. I don't know why my questions haven't already been called because they were submitted last week and Tom acknowledged they were there. So why I've now been fitted in at the end of the meeting, I don't understand. However, I will carry on if that's all right with you.
You may. We are over time, but keep going.
Well,
keep going.
You're not exactly over time. It's quarter to 11, all right? I mean,
keep going.
You're over your 10 minutes, which is not a lot of time to hear from the public. And this will take a few minutes, with your indulgence. With respect to the FNS decision to privatise non-clinical services, and in responding to issues raised by Suffolk KOMP through our legal challenge to FNS, it was stated in the last minutes that Ed Garrett, Chief Executive, thanked Mr. Dooley for raising the issues and stated that the ICB would be interested in seeing them and would give them due consideration. Well, the reason I'm taking up your time now, Ed, is because sadly, you haven't quite satisfied that expectation. The main issue of contention is the repeated assertion of the officers of the ICB that there exists no contractual relationship between the ICB and ESNED with respect to non-clinical services. And therefore, the outsourcing of these services was of no interest or concern to the ICB. Thus stating this position is clearly intended to be definitive, we'd like to press the ICB to record, for the record, to confirm or otherwise the following. Funding from the ICB to FNS within the terms of the NHS standard contract does include FNS costs in relation to non-clinical services, even though these costs are not specified, but assumed to be topsliced from the cost of clinical services. And as a result, the specific measures of reporting and accountability are largely assumed rather than stated in the contract. And secondly, that if current arrangements persist, taxpayers' money to the tune of more than £200 million over the next 5 years will pass from the ICB to ESNEFT without any checks or balances on how this money is spent. That's my first question. Do you want to hear an answer to that first before I go on?
Yes, let's do that. Over to you, Ed.
We have answered those questions before, so I've got nothing further to add. If you want to, we can put that in writing again if that would be helpful, but I've got nothing further to add to previous answers.
Okay, second question.
Well, thank you for that, Ed. Would you confirm actually the specifics of this question, rather than simply stating, as you've always stated before, non-clinical services are nothing to do with us, end of story. Can you please address that issue?
I'll send you a written answer.
Second question is, with respect to the EVNES decision again to privatise its non-clinical services, the Minister of State for Health stated to Parliament on the 20th of November that the government expects the Trust to share its assessment of how the contract meets the public interest test with local stakeholders. Now, EVNES itself has confirmed in response to an FOI request from us that the ICB is regarded as a local stakeholder by the Trust. And this should be no surprise, as the ICB is the principal commissioner of services from EVNES and provides funding under the NHS standard contract, as I've previously detailed. However, a similar FOI request to the ICB elicited the extraordinary and rather dismissive reply that it's a matter of opinion as to whether the ICB is a stakeholder or not, and therefore not a matter covered by the FOI, and that answers to our subsequent questions were not applicable. I mean, I'm rather outraged by this, really. We're therefore obliged to try again and take up valuable time in your meeting today. So please now, can you confirm that the ICB does fall under any reasonable definition of the expression local stakeholder in the parliamentary answer? That's one. That the ICB has at last obtained and studied key documents regarding the outsourcing decision. And nearly finished. Get to the second page.
All right, take your time. You got it? Do you want to borrow my sheets?
No, I'm all right.
You okay? You got it?
Yeah.
Well done.
Okay, go on. Whether an ICB view has yet been formulated as to the extent to which the decision meets the public interest test, whether this has resulted in the production of any documents which details the ICB position, and whether these are or will be available. And in particular, is the ICB concerned that it is now estimated that the costs of this outsourcing escapade will exceed the costs of the services remaining in-house? Now, I'd just like to say finally, bearing in mind that the ICB has previously confirmed never having seen any of the relevant documents, Suffolk KMP will be delighted to provide you with a copy of the final business case and the extensive minutes of the Trust Board meeting of the 5th of December, at which the decision was made, because they've been recently obtained by us. Thank you very much.
Thank you. And Ed, back to you.
Thanks, Mr. Benson. Now, as with the previous question, I'll send you a written response.
Okay, thank you very much. Okay, thanks very much, everybody. So I've got 10:52 on my clock, so I'm going to call the public meeting to a close, and we'll have a coffee break, a short break, and we'll recommence, should we say, at 11:05 in the private session. So 11:05, please, let's reconvene. Thank you very much, everybody, and have a good rest of the day. Thank you.